Bismillahirrahmanirrahim. Continuing with the question number 61. A 55 years old woman comes to the physician for the annual physical examination. She has no new complaints except fatigue. Okay. She has an 8-year history of chronic low back pain. Severe degenerative joint disease have been documented on MRI. She had an anterior wall myocardial infarction for 4 years ago. Her current medication include naproxen, acetaminophen, oxycodone, aspirin, atenolol, and simvastatin. Her blood pressure is 130 by 80 millimeters of mercury and pulse is 72 per minute. Lab studies are as follows: hemoglobin is 10 grams per deciliter. That's kind of low. WBCs are 66,000 per cm by cmm. Okay, 60,000 per cmm. Then we have blood sugar per cubic millimeter, so it's millimeter cube. Blood sugar is low, that is 82 milligrams per deciliter. BUN is high, that is 36 milligrams per deciliter. And serum creatinine is also high, that is 2 milligrams per deciliter. Urinalysis shows protein, that is 2 plus. The glucose is absent, RBCs are absent, WBCs are present, that is 10 to 15 HPF per SPF. And sediment is WBC. Sediment shows WBC casts as well. The serum protein electrophoresis is negative for monoclonal gammopathy. 2 years ago, her BUN level was 22 milligrams per deciliter and creatinine level was 1.6 milligrams per deciliter. Which of the following is most likely pathology involved in the patient's renal failure? And the options are acute tubular necrosis, chronic glomerulonephritis, tubulointerstitial nephritis, or recurrent pyelonephritis. The answer among these choices is option Charlie, that is tubulointerstitial nephritis. Educational objective of this question states that analgesic nephropathy is most common form of the drug-induced chronic renal failure. Papillary necrosis and chronic tubulointerstitial nephritis are most common pathologies seen. Patients with a chronic analgesic abuse are more likely to develop premature aging, atherosclerotic vascular disease, and urinary tract cancer. The discussion is stating that analgesic nephropathy is most common form of the drug-induced chronic renal failure. It accounts for 3 to 5% of end-stage renal disease in the United States of America and is most commonly seen in the females peak at age 50 to 55 years who habitually use combined analgesics, for example aspirin and naproxen. It is generally seen after cumulative ingestion of 2 to 3 kgs of index drug, 2 to 3 kgs, that is 4.4 to 6.6 pounds of the index drug. The papillary necrosis and the chronic tubulointerstitial nephritis are the most common pathologies seen. Polyuria and sterile pyuria, that is WBC cast, may also be seen are early manifestations. Microscopic hematuria and renal colic. Microscopic hematuria and renal colic may occur following the sloughing of the renal papilla. Hypertension, mild proteinuria, and impaired urinary concentration commonly occur as the disease advances. In severe cases, nephrotic range proteinuria can be seen. Patients with a chronic analgesic abuse are also more likely to develop premature aging, atherosclerotic vascular disease, and urinary tract cancer. The choice alpha, that is acute tubular necrosis. This is not the option of choice because acute tubular necrosis causes acute renal failure rather than insidious progression to the renal dysfunction. It is most commonly seen in the ischemic or nephrotoxic acute renal failure. Muddy brown granular casts are characteristic in that case. The choice beta, that is chronic glomerulonephritis. This is not the option of choice because the glomerulonephritis manifests as nephritic syndrome. Hematuria, RBC cast, edema, hypertension, and proteinuria are characteristic. The choice delta, that is recurrent pyelonephritis. This is not the option of choice because chronic pyelonephritis can cause chronic tubulointerstitial nephritis. Chronic tubulointerstitial nephritis, however, it is associated with a history of recurrent urinary tract infections and symptoms of fever, back pain, and dysuria. The next question is question number 62. And in this question, they are asking about a 38 years old woman comes to the office due to intermittent abdominal bloating and diarrhea for the past 2 months. The patient has 5 or 6 loose, large volume greasy stools a day. These episodes are often severe after meal, but there are no specific foods that trigger the symptoms. She has a history of morbid obesity and lost 30 kgs after undergoing ROX and gastric bypass surgery 2 years ago. Other medical conditions include hyperlipidemia and hypertension, both of which improved after the bypass surgery. The patient used to drink alcohol occasionally but has been abstinent for the past 5 years and does not use tobacco or illicit drugs. She takes multivitamin daily and has taken no antibiotics recently. The patient has no history of recent travel on exposure to anyone with a diarrheal illness. Temperature is 37 degrees Celsius, that is 98.6 degree Fahrenheit. The blood pressure is 130 by 84 millimeters of mercury, and the pulse is 78 per minute. BMI is high, that is 34.2 kilogram per meter square. Abdominal examination shows mild diffuse tenderness to palpation without rebound tenderness. The bowel sounds are increased. Stool testing demonstrates increased fecal fat but is negative for occult blood. The lab results are as follows: leukocytes are 9000 per millimeter cube, that is high. Hemoglobin is 11 grams per deciliter, that is okay. Mean corpuscular volume is high, that is 106 micrometer cube. Then we have platelets that are 275 1000 per millimeter cube. The serum chemistry is potassium is 3.5 milliequivalents per liter. I guess it is low, 3. But I guess the range is 3.5 to 5.5 something. Okay, I'm not sure. So it is 3.5. Bicarbonate is 22 milligrams per liter. That is okay. Creatinine level is okay. Calcium level is kind of low, 78, because the average level of calcium is near about 10. The glucose level is 110 milligram per deciliter. Albumin level is 4. The erythrocyte sedimentation rate is 11 millimeters per hour. Which of the following is most likely cause of the patient's symptoms? And the options are dumping syndrome, Giardia lamblia infection, inflammatory bowel disease, irritable bowel syndrome, lactose intolerance, or small intestinal bacterial overgrowth. And the answer is option F, that is SIBO, or small intestinal bacterial overgrowth. Educational objective of this question is over here. So, small intestinal bacterial overgrowth is characterized by bloating, flatulence, and watery diarrhea. Malabsorption and nutritional deficiencies may also occur. SIBO is a common complication of the gastric bypass procedures. Conditions that alter the intestinal motility, for example, systemic sclerosis, diabetes mellitus, and anatomy, for example, stricture, or gastric bypass. Gastric pancreatic secretions, for example, the atrophic gastritis and chronic pancreatitis, also predisposed to SIBO, that is small intestinal bacterial overgrowth. Now, in the discussion, they have given us a table, and in this table they are stating the etiologies of the small intestinal bacterial overgrowth, which are anatomical abnormalities, for example stricture and surgery, motility disorder like diabetes mellitus and scleroderma. Signs and symptoms are abdominal pain, diarrhea, bloating and flatulence, malabsorption, weight loss, anemia, and vitamin deficiency. The diagnosis is done. Diagnosis is done by the jejunal aspirate in culture showing more than 10 raised to power 5 organisms per ml. Carbohydrate breath testing is testing shows lactulose and glucose. Carbohydrate based testing is done using lactulose and glucose. Okay. Organism are streptococci, bacteroids, Escherichia coli, and lactobacillus. Treatment is done by the antibiotics, for example, the rifampin and amoxicillin clavulanate. Avoid anti-motility agents, for example, the narcotics. Don't give them. Then dietary changes, for example, high fat and low carbohydrate diet, and pro-motility agents, for example, the metoclopramide. The treatment: the patient has abdominal bloating, steatorrhea, elevated fecal fat, and the macrocytic anemia. Okay. In the setting of ROX NY bypass, the presentation suggests small intestinal bacterial overgrowth, that is SIBO. The proximal small intestine normally contains minimal bacterial colonization. So, bacterial colonization. Let me complete the sentence, then I will tell you about these telegram channels. The proximal small intestine normally contains minimal bacterial colonization due to gastric acidity and peristalsis. However, the gastric bypass procedure results in a blind loop of intestine that allows for the excessive bacterial growth. Conditions that alter the intestinal motility, for example, the systemic sclerosis and diabetes mellitus. Anatomy, for example, strictures, and gastric pancreatic secretions, for example, the atrophic gastritis, chronic pancreatitis, also predisposed to the SIBO. Now, these are the telegram channels, a lot of them. You can use these telegram channels to get access to this PDF that I am reading. For that, you should go to this one, telegram t.me/uworld step 2ck, and to join other chats for different resources like Kaplan Classroom or Boards and Beyond, Pixelize and stuff like that, you can access through these channels. Now let's come back. Patient with a SIBO typically develop bloating, flatulence, abdominal discomfort, and watery diarrhea. May develop bloating, flatulence, abdominal discomfort, and watery diarrhea. In severe cases, malabsorption, for example, steatorrhea, and weight loss are seen. The lab studies are frequently normal but may demonstrate nutritional deficiencies, for example, vitamin B12 and fat-soluble vitamins, and associated macrocytic anemia. The diagnostic tests include carbohydrate breath test, lactulose, glucose, that measure the production of the hydrogen by the intestinal flora. Endoscopy with a jejunal aspirate and culture showing increased bacterial burden are also used. Management involves correction of the underlying abnormality, dietary modification, and short course of empiric antibiotics, for example, rifampin. The choice alpha, that is dumping syndrome. Let me come back. So over here they're saying dumping syndrome. This was not the option of choice because the dumping syndrome is a complication of the gastric bypass and occurs when high carbohydrate foods are rapidly emptied into the small bowel, leading to the osmotically driven fluid shifts from plasma to the intestine. Although patients have abdominal pain and diarrhea soon less than 30 minutes after meal, the fluid shift results in sympathetic activation, leading to the tachycardia, diaphoresis, and flushing. Hypoglycemia may also occur. The dumping syndrome is not associated with the steatorrhea or vitamin B12 deficiency, that is macrocytic anemia. The choice beta, that is over here, Giardia lamblia infection. This is not the option of choice because the Giardia lamblia infection, patient with the Giardia lamblia infections commonly have steatorrhea and diarrhea, flatulence, fatigue, and significant weight loss. Affected patients frequently have a history of immunosuppression or recent travel. The option Charlie, that is all the way over here. So they are inflammatory bowel disease. This is IBD. This is not the option of choice because inflammatory bowel disease is associated with diarrhea, weight loss, and anemia. Stools typically demonstrate gross or occult blood, and patients may also have extra-intestinal symptoms, for example, fever, and elevated inflammatory markers. The choice delta, that is irritable bowel syndrome. This is not the option of choice because irritable bowel syndrome is characterized by chronic abdominal pain, altered bowel habits, and symptoms reliefs after a bowel movement. Steatorrhea and macrocytic anemia are not typical, and this patient's history of the bariatric surgery make the SIBO more likely. Then we have choice eta, that is over here, all the way over here. Lactose intolerance. This is not the option of choice because the patients with lactose intolerance usually have symptoms, for example, diarrhea, bloating, cramps, after consuming lactose containing products. In this patient, signs of malabsorption and the lack of clear food trigger make the diagnosis less likely. The next question is question number 63. There is a 56 years old man comes to the office for follow up. He has type 2 diabetes mellitus of 15 years duration, hypertension and hyperlipidemia. His diabetes mellitus is currently managed with metformin and glimepiride. Metformin and glimepiride. HbA1c level is 8.5%. Switching to insulin therapy to attain better glycemic control is discussed with this patient. Achieving a goal hemoglobin HbA1c of 6.5% with the use of insulin is most likely to reduce the risk of which of the following complication over the next 5 years. Option alpha, all cause mortality. Option beta, hypoglycemia. Charlie, myocardial infarction, retinopathy, or stroke. And the answer is option delta, that is retinopathy. Educational objective of this question states that in patients with diabetes mellitus, intensive blood glucose control with the insulin decreases the risk of microvascular complications, for example, retinopathy and nephropathy, but has an uncertain effect on the macrovascular outcome, for example, stroke, myocardial infarction, and the mortality. Very strict glycemic control, for example, goal A1C of less than equal to 6.5% is associated with the increased risk of hypoglycemia and increased cardiovascular mortality. Therefore, the recommended target hemoglobin A1C for most non-elderly patients is 7%. Then over here, effect of intensive glycemic control in type 2 diabetes mellitus, macrovascular complications, for example, acute myocardial infarction and stroke. So there is no change in short term. Microvascular complication, for example, nephropathy and retinopathy, they improve with insulin. Then we have mortality. There is no change or maybe increased because of hypoglycemia and complications associated with that. The chronic hyperglycemia in diabetes mellitus is linked to increased mortality and morbidity from microvascular, for example, retinopathy and nephropathy, and macrovascular, for example, cardiovascular disease complications. However, the use of pharmaceutical interventions to achieve glycemic control appears to have mixed effects on reduction of mortality and macrovascular complications. Major randomized controlled trials, for example, United Kingdom prospective diabetes study, UK PDS action to control the cardiovascular risk in diabetes accord suggests the intensive glycemic control, that is hemoglobin A1C of 6 to 7% with insulin or sulfonylurea, for example, glucoside, significantly improves the microvascular endpoints such as retinopathy and nephropathy. In contrast, these trials suggest that intensive glycemic control does not reduce the macrovascular complications like stroke and myocardial infarction or all-cause mortality. Choice A, C, and E. Strict glycemic control with insulin is also associated with significantly increased risk of hypoglycemia, Furthermore, the Accord trial shows very intensive glycemic targets like A1C between 6% to 6.5% appear to increase the risk of all cause and cardiac mortality. Given the established benefits of the glycemic control on the risk of microvascular complications and potential risk of overly strict glycemic control, the recommended target HbA1c for most non-elderly patients is 7%. In addition, the efforts to reduce the risk of macrovascular complications should also include careful management of other lifestyle or cardiac risk factors, that is smoking, blood pressure, and lipids. The next question is question number 64, and here they are asking about a 38 years old man comes to the office due to progressive shortness of breath, cough with mucoid sputum over the past 6 months. His shortness of breath is worse with exertion. The patient has no chest pain. The patient has no chest pain, weight loss, or night sweats. The past medical history is otherwise unremarkable and he takes no medication. He smoked cigarettes 5 years but quit 13 years ago. Here, the patient does not use alcohol or illicit drug. The temperature is 36.7 degrees Celsius. Blood pressure is 128 by 78 millimeters of mercury, that is kind of normal. And pulse is 78 per minute and respiration is 16 per minute. His pulse oximetry is 96% on room air. The BMI is 32 kg per meter square, that is very high. The breath sounds are decreased at the bases. Okay, so breath sounds are decreased at the bases, and there are no crackles or wheezing. Heart sounds are normal. There is no jugular venous distension or peripheral edema. Chest imaging reveals bilateral basilar lucency. Complete blood count and complete metabolic panel are normal. Which of the following is the most appropriate? Which of the following is the most appropriate next step in the management? Option A: in lab polysomnography. B: methacillin challenge test, transthoracic echocardiogram, serum alpha 1 antitrypsin levels, sweat chloride testing, or video assisted lung biopsy. And the answer of choice is option delta, that is serum alpha 1 antitrypsin level. Educational objective of this question is alpha 1 antitrypsin deficiency should be considered in the patients who lack the typical risk factors for the chronic obstructive pulmonary disease, age less than or equal to 45, or those with the atypical features, for example bibasilar predominant disease. Diagnosis is confirmed by measuring the serum AAT level. Then over here you can see the discussion. The patient with a chronic shortness of breath, productive cough, and evidence of destruction of the lower lung lobes likely has alpha 1 antitrypsin deficiency. Alpha 1 antitrypsin deficiency related lung disease presents similarly to other forms of chronic obstructive pulmonary disease but result in pan-acinar panlobular emphysema. Smoking induced centri-acinar emphysema most commonly causes disease in upper lobes of the lungs, whereas the pan-acinar emphysema of the alpha 1 antitrypsin deficiency classically results in the greater destruction of the lower lobes. On average, smokers present in their 30s, whereas non-smokers present in their 40s. Although this patient's complete metabolic profile is normal, alpha 1 antitrypsin deficiency is frequently associated with a liver disease, most commonly resulting in the neonatal hepatitis, cirrhosis, or hepatocellular carcinoma. AAT deficiency should be considered in a number of situations, including a patient with COPD at a young age, that is less than or equal to 45 years, COPD with minimal or no smoking history, basilar predominant COPD, or a history of unexplained liver disease. Diagnosis is confirmed by measuring the alpha 1 antitrypsin levels, and pulmonary function testing should be performed. Treatment includes intravenous supplementation with a pooled human AAT. Choice alpha. That is in laboratory polysomnography. This is not the option of choice because sleep disorder breathing due to obesity such as obstructive sleep apnea confirmed by polysomnography more commonly present with the daytime sleepiness, impaired concentration, and morning headaches. The choice beta, that is methacillin challenge test. This is not the option of choice because the bronchoprovocation testing with methacillin can be used to confirm the asthma diagnosis in selected group of patients such as those with the typical asthma symptoms but normal spirometry. Hyperinflation may be seen on chest X-ray, but basilar hyperlucency is unlikely. Option Charlie, that is transthoracic echocardiogram. This was not the option of choice because an echogram is very useful to evaluate the cardiac sources of dyspnea. However, this patient's pulmonary findings along with the lack of jugular venous pressure elevation and peripheral edema makes a cardiac cause less likely. The choice eta, that is sweat chloride testing. This is not the option of choice because sweat chloride testing is used to confirm the diagnosis of cystic fibrosis. However, adult presentation of cystic fibrosis more commonly characterized by the gastrointestinal, endocrine, and fertility problems. The absence of bronchiectasis on lung imaging also makes the cystic fibrosis less likely. The choice F, that is video assisted lung biopsy. This is not the option of choice because lung biopsy is an invasive procedure with associated morbidity. A measurement of the serum AAT level is less invasive and low values are highly diagnostic for the AAT deficiency. The next question is question number 65, and they are asking about a 36 years old woman. Gravida 0 para 0 comes to the office for frequent headaches, amenorrhea for the last 2 months, frequent headaches and amenorrhea for the past 2 months. The patient has a history, has also had weight loss, intermittent palpitations, vague visual disturbances. Her medical history is unremarkable and she takes no medication. The patient experienced menarche at age 12 and had normal menstrual cycles all her life. She does not smoke cigarettes or drink alcohol. Blood pressure is 130 by 60 millimeters of mercury and pulse is 103 per minute and regular. Her weight is 69 kgs and a year ago it was 76, so she has lost weight. Examination shows a symmetrically enlarged non-tender thyroid gland. Auscultation of the chest shows tachycardia with regular heart rhythm. A fine hand tremor is also noted. The remainder of the physical examination is unremarkable. Lab, result, lab results show serum T3 of 222 nanogram per deciliter. The serum TSH is 6 microgram per units per ml, and serum T4 is 13.9 microgram per deciliter. Which of the following is the most likely diagnosis? Which of the following is the most likely diagnosis in this patient? So the most likely the options are generalized resistance to thyroid hormone, Graves' disease, Hashimoto thyroiditis, normal pregnancy, surreptitious thyroid hormone intake, or TSH secreting thyroid adenoma. And the answer choice is option F, that is TSH secreting pituitary adenoma. Educational objective of this question states that TSH secreting pituitary adenoma causes hyperthyroidism with elevated thyroid hormone and elevated or inappropriately normal TSH levels. Most TSH secreting tumors are macroadenomas and can be associated with the mass effect symptoms including the headache, visual field defects, and impaired function of surrounding pituitary tissue. Coming to the flow sheet diagram, so evaluation of hyperthyroidism. Measure the TSH, free T3 and T4. Primary hyperthyroidism is associated with the TSH. If it is primary hyperthyroidism, the TSH will be low, while free T3 and T4 are high. Signs of grave disease, that is goiter plus ophthalmopathy, present or absent. If there are no signs of grave disease, if there are signs of grave disease, then label it Graves' disease. If there are no signs of grave disease, then do the radioactive iodine uptake scan. If the radioactive iodine scan is high, then see the pattern. If it is in the diffuse pattern, then it is Graves' disease. If it is in the nodular pattern, then it can be toxic adenoma or multinodular goiter. Then radioactive iodine uptake. If the radioactive iodine uptake is low, measure the serum thyroglobulin. If the thyroglobulin level is high, it is thyroiditis and or maybe iodine exposure. And if the thyroglobulin level is low, then exogenous hormone uptake can be a chance, can be the diagnosis. This patient has clinical features of central hyperthyroidism, elevation of both the TSH and thyroid hormones. So it is central hyperthyroidism, that is elevation of both the TSH and thyroid hormones, associated with a tumor mass effect, that is headache, visual symptoms, impaired production of other pituitary hormones. Although uncommon, a TSH producing pituitary adenoma is the likely cause of the patient's hyperthyroid state. Most TSH secreting pituitary adenomas are macroadenomas. Patients with this condition typically have a goiter due to the effect of TSH on growth of the thyroid follicles. However, they do not have the extrathyroidal manifestations of the Graves' disease such as infiltrative ophthalmopathy or prediabeal myxedema, etc. Lab testing show a high concentration of circulating thyroid hormone with an elevated or inappropriately normal TSH. By contrast, patients with non-TSH dependent hyperthyroidism, much more common, will have suppressed TSH. The choice alpha, that is generalized resistance to the thyroid hormone. This is not the option of choice because resistance to the thyroid hormone is an autosomal dominant condition due to mutations in the thyroid hormone receptor. Patients have elevated T3 and T4 and normal to elevated TSH levels, often with an associated goiter. However, this patient is clinically hypo, not hyperthyroid. This patient is clinically hypothyroid, not hyperthyroid. The choice beta and Charlie, which are Graves' disease and Hashimoto thyroiditis. None of them are the options of choice because Graves' disease is an autoimmune disorder associated with the antibodies to the TSH receptor that stimulate the release of thyroid hormone. Chronic lymphocytic thyroiditis, that is Hashimoto thyroiditis, is associated with the thyroid peroxidase antibodies and can cause transient hyperthyroidism due to inflammatory destruction of thyroid follicles and release of thyroid hormone. The hyperthyroidism in both of these common disorders is TSH independent and TSH is suppressed. The choice delta, that is over here, the normal pregnancy. So this is not the option of choice because normal pregnancy is associated with the upregulation of thyroid hormone production due to the increased thyroid binding globulin and stimulation of the TSH receptors by the HCG. However, feedback inhibition of TSH secretion is intact, and pregnant women with clinical hyperthyroidism will have suppressed TSH. The choice eta, that is over here, surreptitious thyroid hormone intake. This is not the option of choice because the surreptitious intake of the thyroid hormone is occasionally seen in the patients who are attempting to lose weight. In such cases, the TSH is suppressed and thyroid would not be enlarged. So we'll keep the session till here and we'll continue with the question number 63, 66 in the next session. Until then, Allah Hafiz, fi amanillah, and take care.